Why hello again, my name's Dee Campbell, and on today's video we're going to be talking about modifiers and how to make certain you're using them properly to maximize revenue and also reduce your denials. As you can see, this one looks a little bit different. I decided to make this presentation in Adobe instead, just because I like enhancing my skills and trying to learn new talents every single day. That way I can be more proficient at my roles. Sadly, I didn't realize it was going to come out in this portrait mode, but I'm hoping with the way I'm cropping it, things will work well. If this does look awful, please leave a comment and let me know, and I will gladly redo it in landscape format. Otherwise, please review the file in the Google Docs, so that way you have the job aid. We'll start with some of the easier modifiers first, and then progressively move on to some of the harder ones. One of the modifiers that almost everyone's aware of are our directional modifiers for right and left side procedures. However, a lot of people will miss the hand and toe modifiers, where each of the fingers and toes have their own individual modifiers to indicate which finger or toe was worked on at that time. How modifier 50 works is if the surface is a part of a bilateral indicator that allows the use of modifier 50, you will then get an increased payment of 150%. While the finger and toe modifiers let you know specific sites to increase the quantity. So for example, a patient presents for finger burst injections in the middle joint of their left ring finger, middle, pinky, and their right middle finger. If a coder or provider just bills this as 2600, modifier 50 in a quantity of 1, you're only going to get paid 150% of that value. Well, instead, if you use that 2600 code with the 4 different finger modifiers, you can now report it as a quantity of 4, and you will get paid for all 4 of those. 2600 has a medical unlikely edit of 6, meaning you can bill a maximum of 6 of these per a day's visit. So you can get away with actually reporting the quantity of 4 as long as you report the modifiers right. So quite simply, if you go this way, you're looking at only about 150% of your payment. Well, if you go this way, you're probably going to be looking at, instead you get about 80% of the rate. So we're looking at still about 320% more. So obviously, significantly better to break down your sites by fingers and toes when it is possible. The next modifiers we'll work on is 26 in modifier TC. These are used for radiology orders. This looks like a lot, but really it's not. It's just all the information in a single page document, but really they're quite easy to work with. Modifier 26 is just quite simply the professional component of a test, meaning the interpretation and the reviewing of the test. You will only use this in situations that you are billing just for the professional component of a test. So meaning you didn't actually own the equipment that was used for the radiology testing, but you will do the interpretation and you're going to bill for it separately. TC, on the other hand, is the technical components of the test. You will bill TC on every single radiology order when you are only performing the technical component of it. Technical component just means the provisioning of the equipment and supplies. So meaning you used your X-ray machine. So whenever you report a radiology that then gets sent out to an actual radiologist to be interpreted, you're just going to use the TC modifier on your X-rays. If you don't report these modifiers, then you are doing what's known as global service billing, which means you're reporting that you did both the professional and technical components of it. So make certain you're always reporting your radiology orders to the highest level possible when it comes to modifiers. Because otherwise what's going to be happening is you're going to be billing for services that you didn't actually complete. These modifiers change the revenue payment of each of these radiology CPT codes. So if you don't put a TC on it, you're billing it globally. The payer's not going to actually know, and they might just approve the payment, and thus you're going to get paid more than you should, which is technically fraud. So just be aware of TC and 26 modifier. Report them on the radiology orders based off of what your practice does. If you do all your own in-house x-rays and you have your own radiologist interpreting tests, or the providers themselves are interpreting the test, then use a global. If you supply the devices, then use a technical. If you're doing only the professional component, which honestly I haven't really even seen ever in my career that I can think of, then you would use 26 modifier. The only exception for this is EKGs, because they have their own specific codes, where 90305 is for EKG with tracing, 93010 is EKG of the interpretation and reporting, and then finally 93000 is the global version of an EKG. And that's simply it. It seems like a lot, but it's really not. Just remember, you must report these modifiers on every single radiology order, so that way you're not charging more than what you should. The next modifiers to be aware of are the QW modifiers. These are actually really easy modifiers. These are just modifiers that get added to the labs to make certain it indicates to your payers that it's a CLIA lab. Basically, the QW lets you know that it gets paid for it. Currently, only Medicare, Medicaid, and UHC is the only commercial payer that requires the use of QW modifier. Novitas has this really nice table for the breakdown. Basically, you just add it if it's on the list. Medicare updates the list every quarter for what tests are a part of the CLIA list. Just download that Excel document, and that way you know when you're adding the QW modifier. Just make certain you add it whenever you're dealing with these payers to make certain you're getting paid for your labs that are CLIA-waived. You don't want to get denied for your labs for something as silly as you're not adding QW modifiers. Next modifier to be aware of are the JW and JZ modifiers. These are important for every single drug code that you report. Basically, whenever you're reporting a HCPCS code, you're going to want to use a JW and a JZ modifier. What each of these modifiers indicate is the story of what happened at that patient's visit. The first visit that we're going to break down is when it's a single dose container and you have to discard amounts. These codes exist because obviously it costs a lot of money to buy medicine, but you might not be actually administrating all of the medicine. So these exist so then that way you'll still get paid for what you use. So how you will report these is the first claim line is going to be the actual amount of drugs administrated. You're just going to use the HCPCS code. The number of units will be associated to the amount of drugs administrated and no modifier required. The second care line, though, will be the amount wasted. So let's just say, for example, we have a 5 milliliter vial. We inject 2 milliliters, and then we waste 3. We will have one line with the quantity reflecting the 3, and we'll have one with the quantity reflecting the 2. That way we're indicating how much medicine was wasted. And then that way you as a clinic aren't losing money on wasted medicine, and you're only reporting what was administrated. That's what these codes are for, is to indicate it. Well, these modifiers are for. Well, JZ modifier, on the other hand, is for indicating that no waste happened. You will just report this anytime you use the exact amount of a single dose vial. So for example, when a patient comes in for their birth control injection, it's usually at the exact 150 amount, so there's no waste. You will report the JZ modifier on that, what is it, J1050, I think is the depot code. You'll report it each and every single time on that JZ to indicate that there's no waste. We must report these codes every single time we're dealing with the J code to let insurance know how much was wasted. The only time we won't report this is if it's not a multi-dose, if it is a multi-dose vial, you won't report it. And then there is technically an approved list of codes that are qualified for it. Please review that list of medicine codes that aren't eligible for it. Personally, I haven't found one not on the list yet, but really, there is a list of non-approved drugs. So just be aware of that. And then finally, I assembled a lot of different policies for payers. Pretty much every single commercial payer is going to be using these as well. So just be aware, if you're ever dealing with a JHCPCS, make certain you add a JZ if nothing is wasted, or a JW if there is waste. You want to report to the highest level medicine administrated in each visit. The reason for this is obviously coding is used for reporting on a higher level too, where people will take all this information and then that way they can maybe change their vial size if people are always administering one size. That way we can do better healthcare. So just remember, coding is all about reporting. We got to report the story of that visit, so then maybe someone else can compile those thousands and thousands of data points and maybe figure out there's a better way to care for a specific condition. That's why coding is so important. Our role is we make the spreadsheet that allows care to get better. Global surgery modifiers to be aware of. Basically, I want to just break down the importance of some of these key global surgery modifiers. The first one is obviously 25 that we're all aware of. I'm not going to break it down completely, but I just want to do this key phrase here for people to remember. Just significant, separately identifiable. Just remember those 3 words in your head every single time, and it's going to be really easy to add this modifier and do split visits. Just remember that every single time was what I did, significantly, separately identifiable from the usual service that would be in like a physical, let's say. Pretty easy to work with. Modifier 54 and 55 are incredibly important modifiers. These modifiers indicate how a procedure is going to be built by a team. What happens is these modifiers indicate how the global service is going to happen. So let's say, for example, a patient reports to an ER with an arm fracture, and coders report that the provider did the procedure to stabilize it and everything. They fixed their fracture, and they reported it without modifier 54. What happened now is when an orthopedist or someone else does follow-up post-operative care, they're not going to be able to bill for that service because the first service was billed improperly. However, if they did bill that stabilization with just a modifier 54, then future providers can actually bill for those services. I have more expanding on this on the next slide here, but just wanted to expand on that. Modifier 57, I just want to point out, specifically has a carve-out separating it from modifier 25. Just make certain you use modifier 25 when it's a decision for a basic procedure. Modifier 57 is when it's more a major surgery is happening. So don't just use it when it's a provider decides to do like a regular incision and drainage. Then you'll use the significantly separately identifiable modifier 25. The next one I want to address here is just the staging ones, which honestly they're not as important. Instead, I wanted to do the 78s and 79s. These are for when someone is in a global period, but something completely unrelated or way outside of the norm is happening, and thus you are trying to get paid outside of the global period. For example, a patient has, let's say, a hysterectomy. A hysterectomy is a major surgery with a 90-day global, so all post-operative care is related to that procedure, and you will continue to report that procedure code with modifier 55 for post-operative care only. However, let's say something very unusual happens, like maybe there's poor adhesion and the wound splits open and now they're doing continued care. You will then report these 78s and 79s to indicate that yes, this patient is in the global period. However, what is happening is so outside of the norm that this isn't normal post-operative care, and we should get paid for this care that we're providing. So finally, I just got a breakdown of the surgical care and how these ones will work, since it's just such an important concept. Specific billing guidelines must be followed when surgical procedures and post-operative care is split between different physicians. Modifier 54 and 55 are used to indicate 2 different physicians are rendering the surgical care and post-operative management service, where physicians agree on transfer of care during a 10-day or 90-day global period. So what we'll use these for is the physician rendering the service will bill the service as the date of service plus the procedure code of the surgery with modifier 54 on it. Well, in the post-operative care, we're still going to build the procedure code. I know it feels weird, but that is how it works. And then you're going to put modifier 55 on that service. In the cases where the surgeon also cares for the patient for surgery periods following discharge, the surgeon should still bill with the modifier 55 and indicate the portion. So even if it's the same physician doing both, it is still recommended that you split the codes for whenever you're doing these global services. And finally, they have an example down here at the bottom for how it breaks down. A physician performs a hysterectomy in the hospital on 4/15. The procedure has a 90-day global period. The patient was in the hospital for 8 days until 4/23, during which time physician A administered postoperative care. On 4/24, physician B took over the postoperative care, which was administered in the office. So physician A is going to bill the procedure that they performed with modifier 54 to show the surgery only, but they're also going to bill for it with postoperative care only. This is going to indicate the postoperative care that they performed during this 8-day period. Will provider B, when they take over their service, they're also going to report that same procedure code with modifier 55 in postoperative care assumed for the 82 days. So once again, why is this so important that we report it as the procedure code? Is remember, coding is all about making reports. This is reports for other people to interpret. We have to report the procedure code every single time for the post-operative care, because this will make great reporting in the future to let everyone know how many follow-up visits are on average with a hysterectomy. You have to think about coding as a beautiful data pool of everyone's information pooling up into one major resource that then can make care better for everyone. And that way we can find maybe carousels that didn't work. So that's about it. These are the important modifiers for coding. My name's D. Campbell. Just remember, your modifiers will affect your denials a lot more than people realize. It can also affect your payment amount. In this case of the finger example, you might be underreporting your services and getting paid too little because you're not using these services. Or on the other hand, for x-rays, you might be not reporting your modifiers right and you're overbilling for your services. So just be aware of how important these modifiers are, so that way you're telling the patient's whole story. You got to remember, what happens is everything that happens to that patient becomes a single. It is up to us to make that one-page document as informative as possible. My name's D. Thanks again.